live.
Yeah, good afternoon. Today we start the WFNS Spine Committee Symposium on Adult Spinal Deformity. We have excellent speakers with us now. My co-chairman, Professor Ramani, is there all the time with us.
I'm there very much.
Yeah, yes, sir.
Yeah.
So we start with the first talk with Salman, giving a talk on biomechanics of spinal deformity. Salman.
Dear friends at NSSA and Spine 2021, I'm grateful that you're invited the WFNS Spine Committee to be involved in the Spine Deformity webinar. I'll be talking about biomechanics of adult spinal deformity. I'm grateful to everyone who's involved here, and it's wonderful to be back sharing knowledge with you. Well, I come from Pakistan, and just like India, Pakistan has some amazing areas in the northern part of Pakistan. What is deformity? We define it by deviation from normal shape or size. Spinal deformity generally has one major and one minor structural curve. Major and minor curves form a pattern. There are primary or secondary curves. Primary, obviously, idiopathic or secondary to known spinal abnormalities. You could have single or combination of three planes deformity. Basic types are scoliosis, kyphosis, and lordosis, and it could be single or in combination. There are some terms that we need to know. So thoracic deformity is the apex between T2 all the way to 211, 12. Thoracolumbar is obviously T12 and L1. Lumbar between L1, 2. And it's distal to L1, 2 and to the disc itself at that level. Scoliosis, if it's to the right, it's right-sided scoliosis or dextroscoliosis. If it's to the left, then it's going to be levoscoliosis or left-side scoliosis. Then these are terms like end. So end vertebra is end of scoliosis curve, that the vertebra that tilts maximally into the concavity of the curve, and you can see these two are those vertebrae. So you could have rostral, which is, and the caudal. So rostral is here, the caudal is here. And this is the first vertebra in the caudal direction, which forms a curve apex, whose caudal surface is tilted maximally towards the concavity of the curve. And you can see these are the two vertebrae or end vertebrae. Then there is an apical vertebra. It's maximally laterally displaced and minimally angulated vertebra or disc of the curve. So it could be either this or the disc over here. So either the vertebra or the disc itself. And then there's apical vertebra translation. Proximal thoracic is the main thoracic curves, horizontal distance between the C7 plumb line to the center of the apical vertebra. That's how we measure those curves. Thoracolumbar and lumbar we take from the central sacral vertical line, which is from the bottom, and again to the center of apical vertebra. So if you have a line drawn from there, these would be the thoracolumbar curves. What about proximal and distal neutral vertebra? So these are not rotated in axial plane, and they allow fusion level to be selected. So we go a couple of levels above and below to make sure that we completely fix the deformity. And then there is a stable vertebra above and below the end vertebra that is bisected by CS. So this is the sacral vertical line which bisects it. So this will be, this is the level that is the stable vertebra, which is below the neutral vertebra. How do we measure COP? It's simple assessment described in 48. Select vertebra maximally tilted. So for example, these one above and below, we take the superior end plate of the level above and the inferior end plate of the level below. And then we can take these lines across and we can measure the angle. Since we don't have enough space here, so we take a perpendicular line and then we join these lines together. So bisecting perpendicular lines, and this is the angle that we're going to be measuring. So COB angle is found by this particular method. What about apical vertebral rotation? So it is a rotation about the long axis of the spine, and you can see in this particular case, we can see the whole thing moving. There's an Ashmore classification defined in AP X-rays or CT. Generally, we take CT. It categorizes vertebral rotation into 5 grades based on the location of the pedicle in relation to lateral aspect of the vertebral body. So if no rotation and pedicles are normal, then we have got rotation with pedicle moving slightly towards the midline. Rotation, 2/3 of the pedicle already moved, In this, the pedicle is in the midline and the other pedicle is not visible, and the pedicle goes beyond the midline in this particular case. And so you can see this is convex and this is concave. Then we have usually more than one curve in deformity, as we just said. The largest curve is a structural curve. It does not completely correct on bending. So obviously then this is the largest curve, which is the main curve. And then we have a compensatory curve, responds to the main structural curve and serves to maintain sagittal spinal balance, may or may not be structural. And you can see thoracic curves persist, and therefore structural. Lumbar curve, it gets corrected and this non-structural. Overall coronal balance we can define, from these points till sacrum. So center of C7 is taken down, and then you have the central sacral line that goes all the way up, and we take it at the midpoint of the thoracic trunk, and this is where we get basically the distance between the spine itself and how much it's coronally unstable. Then you have a thoracic trunk S1 CVA, and which is measured nearly the same way. Then there is a C7 S1 coronal vertical axis. So horizontal distance measured between a line that's drawn from C7 plumb line to CSVL. So CSVL, and this, when it's negative, it is between -1 and +2. And if it's on the right side, we know it's positive, and if it's on the left side, we know it's negative. So this guy says, I don't understand why he's getting shorter. And obviously this mobile phones have caused a lot of deformity in present day and age. Overall sagittal balance is affected by a relationship of spine to the pelvis. So thoracic hyperkyphosis or loss of lumbar lordosis, you've got the head falling anterior to where the pelvis is. So impaired sagittal balance, which leads to hip flexion, and you can see the hips being flexed, and also the pelvic retroversion, which was here and moved on to become retroverted here. So it keeps on moving from partially compensated to completely compensated. And here, the pelvic tilt, sacral slope, pelvic incidence, and even pelvic angle will also come into play. Again, SVA, when you're looking laterally, is horizontal distance from vertical plumb line, from the midline of the C7 to the dorsal rostral line at S1 end plate. If it's positive, then the plumb line is ventral to the sacral reference. If it's negative, it's vice versa. And you can see exactly the same thing, positive and negative. And these are some of the values that have been calculated by various people, and it varies quite a bit. T1 pelvic angle, so it's used in patients who are unable to stand for x-rays, and the center of the femoral head there's a line that's drawn all the way to T1 center, and then there's a line from the center of femoral to the center of the superior sacral end plate. And this angle that we get is T1 pelvic angle, and is less affected by compensatory mechanism. Then we have kyphosis or lordosis. Kyphosis when you've got excessive bending, whereas lordosis is less bending. And then there are regional angles and calculations that need to be, we need to know this, but it's not that relevant, and future will be quite relevant. Thoracic kyphosis angles. So total thoracic kyphosis angle is important, and we know it's between 20 to 50 degrees. It's from the superior end plate of T1 down to the inferior end plate of T2. Then there is a proximal thoracic kyphosis, and then there is a main thoracic kyphosis. Then thoracolumbar junction, and that all is measured exactly the way Cobb is measured. What about lumbar lordosis angles? Generally average is 60 degrees. It's either the caudal end plate of D12 or the rostral end plate of L1. So either one of them to the rostral end plate of the S1 vertebra. And generally, as we said, that it's about 60 degrees. And lumbosacral junction angles are there as well. In some cases, we can use them as well. So sagittal pelvic alignment is very important. We've talked about it a lot. Pelvic tilt is measurement of the degree of pelvic retroversion. It's degree of compensation for sagittal imbalance. Pelvis rotates on the hip axis to help maintain balance. So this angle is an angle that we can detect by a vertical reference line through the hip axis, and a line drawn from the midpoint of the sacrum to the sacral end plate of the hip axis. So once we have drawn this, you can find an angle, and it's positive if sacral point is posterior. If it's negative, patient will say that hip angle reference point is anterior. What about sagittal pelvic alignment, pelvic incidence? We know that it's nearly uniform, it's unaffected by posture. It's angle that we can detect by a line drawn from the hip axis to the midpoint of the sacral end plate, and a line that is perpendicular to it. And as we said, obviously it is going to be uniform, although you can see as sacral slope changes, reduces, despite that it remains same. And we know that hip axis is obviously calculated a midpoint between the approximate centers of both hips. So if they are aligned well, otherwise you can have a midpoint there. And then the sacral slope. This is the line that we draw by a sacral end plate line that goes across that, and then a horizontal line, which is a reference line, and this is the sacral slope. The other thing to remember is that pelvic incidence is equal to sacral slope plus pelvic tilt. So it's nearly always, you can calculate this. Lumbar lordosis and thoracic kyphosis can be predicted from the above parameters. Lumbar lordosis is equal to pelvic incidence plus minus 9, and that's a general figure that you need to remember. What about pelvic alignment and obliquity? So it's angles subtended by a horizontal reference line and a line drawn tangential to the top of the iliac crest, to the base of the sulci of S1L. And once we have that, then obviously that's pelvic obliquity as it. So Ed Benzel came up with these force factors acting on the spine. So he said that there was a force applied into the length of the lever. Depending on that, that's your bending moment. And bending moment affects spinal segment by applying eccentrically, or maybe on one side. So you get kyphosis, lordosis, scoliosis if it's angular. If it's on the axis of rotation, vertebral body and disc will be involved. This is to maintain the sagittal segment. Translation deformity can be sagittally oriented, causing compression and distraction. And if it's axially oriented, it will cause spondylolisthesis. So compression anteriorly here will cause compression anteriorly. So kyphosis, where if it's compression on the top, it will become shortened. The biomechanics pathogenesis could be due to tethering of the posterior elements, and earlier posterior fusion in young children will remain growth potential to cause crankshaft phenomenon. And that's why you can get deformity coming up because of this. So this is just brief summary, and I thank you all for listening.
Yeah, thank you. Thank you, Salman, and it's very nice, short and crisp talk on the biomechanics, which becomes the basic of all of our understanding of the next lectures.